Good evening, all. Sunita ma'am, good evening.
Good evening, Deepa ma'am. Shall we start or?
Yes, ma'am. Yes, ma'am. So, good evening, all, and welcome to the third day of Rapid Review Program, jointly organized by ASMIC and ACCIA or OMR. Today, we have a very eminent person, Dr. Sunita M. She is the professor and HOD of Nurul Islam Dental College. And today, and she has more than 25 years of teaching experience. So today the topic presented by Sunita ma'am is salivary gland diseases, a very important topic from the exam point of view. Warm welcome, ma'am, and over to you for the presentation, ma'am.
Thank you, Deepa ma'am, for the introduction, and a very good evening to one and all. And I am glad to be part of this rapid review session organized by ACCIA College of Dental Sciences and ASMIC, and which will be a useful program for the undergraduates to do a rapid revision of the various topics in oral medicine. So, shall we move on to the session? Hope I am audible to everyone.
You're audible, ma'am.
Are the slides visible?
Yeah, slides. First slide is visible, ma'am.
Okay.
Okay.
So we'll just move on to our session. So the topic of today is salivary gland diseases. So we know that we have three pairs of major salivary glands: the parotid, the submandibular, and the sublingual salivary gland, and minor salivary glands distributed throughout the oral cavity, which occur on the labial mucosa, tongue, palate, buccal mucosa, etc. Now, examination of salivary glands is an important one. And you know that the parotid gland is situated slightly below, behind, and in front of the ear. And so, examination of the gland, you should look for any swellings or masses in the gland. And also, you can look for elevation of the lobule of the ear. And next, the important thing in the examination is you have to look for the ductal orifice. So Stenson's duct is the parotid duct which opens opposite the maxillary second molar onto the buccal mucosa. So you can look for any inflammation of the ductal orifice, and also you look for the salivary secretion, whether there is any pus discharge or bleeding, etc. And the submandibular gland examination is done by bimanual palpation, where you place the fingers of one hand onto the lingual aspect of the mandible in the floor of the mouth and the other finger in the submandibular region, and you do a bimanual palpation. And if the gland is enlarged by any means, it will be palpable. And the submandibular duct is a Wharton's duct, which opens onto the sublingual papilla on either side of the lingual frenum. And also you can look for any inflammation over the ductal orifice in this region. And sublingual gland again is situated immediately below the floor of the mouth in the anterior region. So this gland also can be examined by bimanual palpation. And sublingual gland opens by means of many small ducts, which are called as the duct of Rabinus. And one of the largest duct is called as the Bartholin's duct, which joins the Wharton's duct and opens onto the sublingual papilla. The duct of Rabinus opens onto the crest of the sublingual fold on either side of the lingual frenum. So this is regarding the examination of the salivary glands. So as we have seen, we look for the salivary secretion through the orifice. Now, all these glands, they secrete saliva, which plays an important role in digestion, mastication, speech, swallowing, etc. And also saliva is one of the important diagnostic tools to diagnose various disease conditions also. And so the salivary flow rates can be calculated either from the individual glands or from the mixed sample. So either the whole saliva can be collected or the individual gland saliva can be collected. And similarly, you have the stimulated saliva collection and the unstimulated saliva collection. And the saliva collection is done by different methods like draining, spitting, suction, using absorbent sponge methods, etc. So, and stimulated salivary saliva collection is by means of asking the patient to use a chewing gum, or 2% citric acid can be applied to the dorsum of the tongue, and saliva can be collected. And this is called as xylometry, where you assess the salivary flow rates. So the unstimulated whole saliva flow rate is about 0.1 ml per minute. This is a normal one. And stimulated salivary flow rate is 1 ml per minute. And Carlson-Crittenden collectors are used for parotid gland saliva collection. They are placed directly over the Stenson's duct orifice and they are held in place with suction. Similarly, submandibular and sublingual saliva is collected using an alginate held collector, which is called as the segregator. Now moving on to the classification of salivary gland diseases. So you have developmental disorders, which includes aplasia, hypoplasia of the salivary glands, accessory ducts, etc. And then inflammatory and reactive lesions, which include mucocele, ranula, pyelolithiasis. And you have infectious conditions, which include bacterial, viral infections, and metabolic conditions like sialosis or sialadenosis, immunological conditions, which include Sjogren's, Mikulic's disease, and functional disorders like xerostomia, sialuria, and neoplastic disorders. You have various benign and malignant tumors. Now, moving on to the reactive lesion, one of the important lesion, that is a mucocele. So mucocele is it is a swelling caused by accumulation of saliva at the site of a traumatized or obstructed minor salivary duct. And this can be of the extravasation or retention type. So the extravasation mucocele is due to the traumatic or trauma causing rupture of the duct, which results in the pooling of the mucus into the surrounding connective tissue, which creates a granulation tissue response around it with the connective tissue wall, giving it a pseudocyst-like quality to the lesion. This has no epithelial lining, and so it is called as a pseudocyst. So that's the extravasation mucocele. Whereas the retention mucocele is due to obstruction of the salivary duct by calculus, and which results in the accumulation of saliva and dilatation of the duct, which gives a true cyst-like appearance since it is lined by the epithelium of the dilated duct. So this mucocele appears as a bluish, translucent, dome-shaped swelling, usually on the lower labial mucosa. And transillumination is positive for this lesion. And also aspiration can yield a mucus-like fluid. And it is important to differentiate this from vascular lesions like hemangioma, varix, etc. And treatment will be surgical excision, laser surgery can be done. Now next is ranula. So it's called ranula because it resembles a frog's belly, and they are large mucoceles situated in the floor of the mouth. And they may be extravasation type or the retention type, and you have a superficial type and the deep or plunging type. So superficial type, it occurs superficially in the floor of the mouth, and the deep or plunging ranula is due to the mucus extravasation through the mylohyoid muscle into the facial planes of the neck. So this will be seen as a swelling in the floor of the mouth. And the plunging ranula occurs as a swelling in the neck. So next condition is silolithiasis. So silolithiasis is the formation of calculus in the ducts of the major salivary glands or within the gland themselves. So siloliths are calcareous deposits. They are formed by the deposition of calcium salts around the central nidus, which may be desquamated epithelial cells, bacterial products, or foreign body. And majority of them, they occur in the submandibular salivary gland. And this high incidence in the submandibular gland is due to the high concentration of calcium salts in the secretion, due to the alkalinity or the high pH and the high mucin content in this gland, and also the anatomic location of the Wharton's duct. Its length, it is very long and it has a tortuous course, and it secretes against the force of gravity. That is, the gland is situated in an inferior position, whereas the duct is in a superior position. So, which can lead to stasis and stagnation of saliva, and this leads more to the calculus formation. So, these are the important chemical constituents, which include calcium phosphate, carbonate, sodium chloride, and other rare elements like xanthine, uric acid, etc. So the patient, and the most important feature in clinical finding in silolithiasis will be the patient's complaint of painful swelling of the gland, which is more pronounced just before, during, or after meals. And this is due to the stasis of saliva and the increased salivary secretion on eating food. And the involved gland will be enlarged, painful, and tender on palpation. And if the stones are large enough, they can perforate the duct, forming a fistula into the oral cavity. This is a submandibular silolith. So this is a mandibular occlusal radiograph, which shows the silolith. A silography can be done, which silography is the injection of a radiopaque contrast dye into the duct to have an idea, and then X-rays are taken to have an idea about the duct and the glandular structure. So on silographic appearance, there can be filling defect of the main duct, ductal dilatation due to silodocitis, and the emptying film will show contrast medium retained behind the stone. So, and silodinitis due to silolithiasis can be managed with antibiotics and anti-inflammatory analgesics, and use of lemon and sour substances can stimulate the salivary flow and can help in the removal of very small siloliths. And siloliths that are close to the ductal orifice can be manipulated, and by using salivary stimulants, they can be removed and manipulated out. And larger siloliths will have to be surgically excised. The next condition is necrotizing silometaplasia, which is a benign inflammatory reaction of the salivary gland. And the importance is that it clinically and histologically mimics salivary gland malignancy. And there is a lot of clue to studying about the nature of this condition, in that the name itself is self-descriptive of this condition. So basically, it happens due to ischemia, due to alteration of local blood supply, and the predisposing factors include any traumatic injuries, LA administration, ill-fitting dentures or dental infections, etc., which lead to ischemia, which leads to acinar necrosis, which is followed by squamous metaplasia of the salivary ducts. So metaplasia is alteration of one cell type to another cell type. So everything is self-descriptive in the name itself. So you can remember in that way. So it's more common in men, and the age of onset is 46 years. And the main important feature is that it commonly occurs in the palatal minor salivary glands. And initially it presents as a non-ulcerated swelling. Later on, it can ulcerate. And it takes about 6 to 10 weeks for healing. And thus, clinically, it resembles a malignant ulcer. And histopathologically, there is acinar necrosis followed by a squamous metaplasia. And there is a pseudoepitheliomatous hyperplasia of the epithelium, which resembles carcinoma. But there is preservation of the lobar architecture, and thus it can be used to distinguish from neoplasia. So, symptomatic management will do, since it is a benign self-limiting condition, but biopsy is essential in doubtful cases. So this question is also repeatedly asked for the university exams. So moving on to sialadenitis. Sialadenitis is inflammation of the salivary gland, and the causes include allergic, viral, and bacterial. Now, allergic sialadenitis is due to some pharmaceutical agents or some drugs which cause enlargement of the salivary gland. And the important feature is that there is itching over the gland. Then viral sialadenitis includes conditions like mumps, cytomegalovirus infection, HIV, hepatitis C virus infection. And here, the important point to note is that in bacterial sialadenitis, we see pus discharge from the ductal orifice, whereas in viral sialadenitis, there is no pus discharge from the ductal orifice. This is one important clinical feature. Now, moving on to one of the important viral sialadenitis, that is mumps. It's otherwise called epidemic parotitis. It is caused by an RNA virus, the paromyxovirus, transmitted by salivary droplets. Usually occurs in children. And there is an incubation period of 2 to 3 weeks, followed by salivary gland enlargement. And there is fever, and mostly parotid gland is involved. Bilateral involvement is there. It's tender on palpation. The ducts are inflamed, but there is no purulent discharge. So, and usually it lasts for about a week. And diagnosis is mostly by clinical findings, and you can also demonstrate antibodies to the mumps S and V antigens. Serum amylase levels may be elevated. And another importance of this condition is the complications. There are a lot of complications can occur, like meningitis, thyroiditis, pancreatitis. In males, there could be epididymitis or orchitis with testicular atrophy and even infertility. And so it has to be properly managed. So symptomatic treatment is done. And if there is a secondary bacterial infection, you can give antibiotics. And vaccination is important for prevention of this condition. So it is given at 12 months or older, and the second dose is given at 4 to 6 years of age. Moving on to immune disorders, the most important one is Sjogren's syndrome. This condition is very important in that it is an autoimmune disease, and also a lot of investigations are done to diagnose this condition. And so this is characterized by oral and ocular dryness, and also there is lymphocytic infiltration of the exocrine glands. So you have primary and secondary Sjogren's syndrome. So primary is characterized by dry mouth, dry eyes, and it's not associated with other autoimmune condition, whereas secondary is associated with other connective tissue disorders like scleroderma, lupus erythematosus, etc. So the effect on the eye is called keratoconjunctivitis sicca, and xerostomia and xerophthalmia together is known as Sicca syndrome. So clinical diagnosis, xerostomia and dry eyes along with parotid enlargement. And there are some tests to identify the decreased lacrimal secretions, which is called as a Schirmer test, where you have standardized sterile paper strips which are hooked over the margin of the lower lids, and the amount of tear absorption is measured after 5 minutes. So if the value is below 5 mm, it's indicative of dry eyes. And you have the Rose Bengal dye test, which using this dye, with the defects of the ocular surface epithelium may be demonstrated. And breakup time test is there, which is done to note the presence of dry spot on the cornea on slit lamp examination. And cylometry is the salivary flow rate estimation. This can be done. The normal rate is 0.5 ml per minute. If it is less than that, it is xerostomia. And xylochemistry is the assessment of the chemical constituents of saliva. So parotid saliva in Sjogren syndrome has elevated content of phospholipid and glycolipids. And sodium chloride levels are also higher in the saliva of Sjogren syndrome. Immunologically, if you see, you can find that ESR is high, serum IgG is elevated, positive rheumatoid factor, anti-nuclear antibody is present in some, and also autoantibodies like anti-SSA, anti-SSB, salivary duct autoantibodies, they can be demonstrated. And then xylographic examination, that's also important, which gives a cherry blossom appearance. And scintigraphy will show decreased uptake and delayed emptying of the isotope. And biopsy will show lymphocytic infiltration of the salivary glands. So the histological criteria includes to determine the foci. So 50 or more number of these lymphocytes and plasma cells together is called as a focus. And the number of foci per 4 millimeter square mm is considered as a focus score. So a focus score of 1 or more is considered positive for Sjogren syndrome. So lymphocytic infiltration of the salivary glands. So treatment will be symptomatic treatment with artificial saliva and also corticosteroids will improve the salivary flow. And also you can use systemic cholinergic medication like pilocarpine and cevimeline to improve the salivary flow. And the complications in Sjogren syndrome include malignant lymphomas. Moving on to the next condition, that's Mikulicz disease, which is also an autoimmune disorder characterized by persistent enlargement of the salivary and lacrimal glands. And here there is infiltration of Ig4 positive plasma cells. Females are more affected. Classic signs, dry mouth, dry eye, similar to that of Sjogren syndrome. And treatment is symptomatic treatment and corticosteroids. The next condition is uveoparotid fever. It's a form of sarcoidosis. It's also called as Hereford syndrome. So there's a triad of symptoms like uveitis, which is inflammation of the uveal tract of the eye, and parotid swelling, which is a bilateral enlargement. It's firm and painless, and there is facial palsy. So etiology includes infection, hereditary, and autoimmune. Treatment is by means of corticosteroids. So functional disorders, xerostomia and siloria. Xerostomia is dry mouth and siloria or tyalism is increased salivary secretion. Now, xerostomia, it's a symptom, it's not a disease. There are various causes of xerostomia, like functional causes, which include dehydration, hemorrhage, diarrhea, and organic causes like Sjogren syndrome, radiation, HIV, diabetes, and psychogenic causes like anxiety, depression, etc. And drugs which include antihistamines, anticholinergics, and also local factors like smoking, mouth breathing, nutritional deficiencies like pernicious anemia, iron deficiency anemia, etc. Now, there are some clinical signs of xerostomia which can be done in the chair side, which is one of which is a lipstick sign, where lipstick, when in xerostomic patients, if lipstick is applied, it will adhere to the labial surface of the incisors, maxillary incisors, and this is due to the lack of the saliva. And tongue blade sign, where tongue blade is used and it is moved over the buccal mucosa. In a normal patient with normal salivary secretion, it will easily glide to the mucosa, whereas in xerostomia, the tongue blade will stick to or it will adhere to the buccal mucosa. And cracker sign is the difficulty in eating dry foods like biscuits, etc. And thread sign, in xerostomia means the ability of saliva to be drawn into thin thread-like ropey saliva fashion. And treatment is to correct the underlying etiological factor. So you can different forms of treatments are there, preventive therapy to. And the other clinical features of xerostomia include increased incidence of dental caries, burning sensation, dry and cracked lips, deep appellation of the tongue, increased chances of candidiasis, etc. These are the other clinical features. So preventive therapy will be to prevent against caries by topical fluoride application, and symptomatic therapy. Patient can be asked to drink fluids intermittently. Artificial saliva can be used. And then topical salivary stimulation is by use of chewing gums and sour food substances, lemon, etc. And systemic salivary stimulation is by means of using xylogogues. So xylogogues are drugs or substances which increase the salivary flow, secretion. So the drugs include pilocarpine, cevimeline, bromhexine, anethol triathione, etc. So the next condition is sialosis or sialadenosis. So in this chapter, you have lot of terminologies, and it's important not to confuse one term from the other. So we often find students confusing this sialosis with sialolithiasis or sialadenitis. So you should remember that sialosis or sialadenosis is characterized by non-neoplastic, non-inflammatory enlargement of the salivary gland. So it can be due to causes like diabetes, chronic alcoholism, malnutrition, anorexia, dehydration, pregnancy, drugs like antihypertensives, antithyroid drugs, etc. Commonly in females, and usually it's a bilateral enlargement. Parotid gland is enlarged, and management is by correcting the underlying cause. So moving on to salivary gland tumors. So pleomorphic adenoma is one of the most common benign salivary gland tumor. It's called as a mixed tumor as it contains both epithelial and mesenchymal elements. So most commonly it occurs in the 85% in parotid, 8% in submandibular, and females are more affected than men. So the term pleomorphic denotes its varying appearance histologically by the presence of epithelial and mesenchymal elements, along with cartilaginous, myxoid, and osseous components. So histopathologically, you can see the epithelial and mesenchymal elements, and clinically, if you see, it presents as a slow-growing swelling with well-defined margins. And regarding the tumors of salivary glands, we should be able to know the differences between benign and malignant tumors. So a benign tumor, usually it appears as a discrete, a well-defined swelling with well-defined encapsulated margins. It has a slow growth, and there is no surface ulceration, there is no pain. And in case of parotid gland, there is no facial palsy, there is no underlying bone involvement, and no metastasis. So these are the features of, in general, for a benign tumor. And whereas in case of malignant tumors, they have a rapid growth, and the margins are diffuse usually, and the surface gets ulcerated. There can be pain. And in case of parotid gland malignant tumors, there is facial palsy, and it can extend to involve the underlying bone, which can be detected radiographically, and also metastasis will be there. So these are the two main differences between benign and malignant tumors clinically. And regarding pleomorphic adenoma, histopathologically, as we have seen, it has both epithelial and mesenchymal elements, and myoepithelial cells are also there. And one of the important histopathological feature is that it has microscopic projections outside the capsule. And so chances of recurrence is there if the tumor is not excised with adequate surgical margins because of this feature. So treatment will be surgical excision with adequate margins. So next is Warthin's tumor. It's again benign. So it's otherwise known as papillary cystadenoma lymphomatosum. So it's a benign neoplasm that occurs almost exclusively in the parotid gland and rarely in submandibular and other glands. It arises from the heterotopic salivary gland tissue within the parotid lymph nodes. That's the importance of this condition. And smokers have a greater risk of developing this tumor. So there is a mixture of epithelium and lymphoid stroma. So the epithelium is oncocytic in nature with the uniform rows of cells surrounding cystic spaces. And also it shows papillary infoldings that protrude into the cystic spaces, which is supported by a lymphoid stroma. So moving on to the malignant tumors, the most important of which is adenoid cystic carcinoma. So as we have discussed before, the clinical appearance, there will be ulceration, pain, the pain can be there. And this is one of the most common malignant tumor of the submandibular and minor salivary glands. And unlike a malignant tumor, it has a relatively slow growth, and thus it mimics a benign tumor clinically, but occasionally painful. In case of parotid tumors, it can cause facial nerve palsy. And one of the important features of this tumor is that there is perineural invasion. The slow growth may delay the diagnosis. And bone invasion is there, which can be seen radiographically. Metastasis to lungs is more common than the regional lymph node metastasis. So histopathologically, individual cells are small, cuboidal, nuclear atypia, mitotic figures are rare, but chromatin aggregation is dense. Pseudocystic spaces filled with acellular material is evident. And there is microscopic evidence of perineural or intraneural invasion. So treatment is surgical excision. And mucoepidermoid carcinoma is one of the other malignant tumor of the salivary glands. So 60 to 90% occur in the parotid gland. So here you have tumors of low grade, intermediate grade, and high grade malignancy are there. So intraorally, they occur in the palate, buccal mucosa, tongue, retromolar area. Tumors of, so in this, the tumor of high-grade malignancy, they show rapid growth and produce pain and facial nerve palsy and metastasis. So histopathologically, it contains both epidermal and mucous cells. So, and the classification as either high-grade or low-grade will depend on the ratio of the epidermal cells to the mucous cells. So low-grade tumors are small and they are encapsulated, whereas high-grade tumors, they lack a capsule. And low-grade lesions are composed of mucus-secreting cells arranged around microcystic structures. So the mucus cells are more when compared to the epidermoid cells in case of low-grade lesion. Whereas high-grade and intermediate-grade lesions, they have fewer cystic spaces and mucus cells, and large number of epidermoid cells are seen. And also you will find dysplastic features like cellular pleomorphism, nuclear hyperchromatism, mitotic figures, etc. in high-grade malignancy lesions. So treatment will be based on the location, the grading, and the clinical staging of the tumor. So low-grade tumors are managed by surgery alone. High-grade tumors require wider resection, radical neck dissection, and post-operative radiation therapy may be given for aggressive tumors. So this is in a nutshell about the different salivary gland conditions. And not to forget saliva. So saliva, we learned that it's an important diagnostic tool, and often we find questions are also asked in this way also. So the applications of saliva in diagnosis include in infectious diseases to detect viral RNA, as in HIV, hepatitis, herpes viruses, or the antibodies to these viruses. And then in cancers, it can be used to detect biomarkers for oral, breast, prostate, pancreatic cancers, etc. So the oral cancer biomarkers, important biomarkers include CD44, CYFRA21, tissue polypeptide antigen, CA125, HPV16, etc. And also in case of dental caries and periodontal diseases, markers are used to assess the conditions, and also to assess conditions like diabetes, cardiovascular diseases, liver diseases, etc. And in forensic odontology, it's an important source of DNA for identification in case of substance abuses and hormonal variations, etc. So the advantage is that it's very non-invasive. You can easily collect it and it's cost effective. So that's about the topic of salivary gland diseases. And regarding the questions that have been asked in the universities, we find that Jogden syndrome is mostly asked as an essay question. And similarly, saliva as a diagnostic tool, sialolithiasis, malignant tumor adenoid cystic carcinoma has been asked, sialadenitis, and necrotizing sialometaplasia, ranula, Fraze syndrome, which is gustatory sweating, and mucocele, sialolithiasis, diabetic sialadenosis, sialogogues, etc. So with this, we have come to the end of the session, and I wish good luck to all the students for the upcoming university exams. Thank you.
Thank you, Sunita ma'am, for a wonderful presentation on salivary gland diseases. On behalf of ASMIC and CCA OMR, I extend my sincere gratitude and appreciation for delivering such a session on salivary gland diseases, a clear and precise session, and that is exam focused also. And I hope the depth of knowledge that you shared today will surely serve as a valuable guide in both academic preparation, that is exam preparation, and also for clinical practice. Thank you, ma'am. Thank you once again. And
thank you, Deepa ma'am, for the wonderful opportunity given to me.
Welcome.
In these students.
Any questions from students? Madam is ready to answer your questions. If you have any doubt, you can post it in the chat box or you can raise a hand. And I think Madam has completely covered all the important questions from this topic. With reference year-wise also, she has included in the last slide. Still then, if you have any doubts. No doubts? No questions? Okay, then. Thank you, ma'am. Thank you so much. And I invite Dr. Rajesi, President ASMIC, to introduce our next speaker. And Shabil, can you stop sharing the screen?
Hello. Hello. Am I audible? Hello.
Yes, sir, you're audible, sir.
Yes, Raj, you are audible.
Okay, right. Yeah, so now we move on to the next topic of interest, that is about the xylography. And Dr. Gigi Roy is here. She is from senior lecturer from Indira Gandhi Institute of Dental Science and Hospital. She finished her BDS from Vinayaka Mission Sankaracharya Dental College and her MDS from Mar Baselios Dental College. She has several national publications to her credit, as well as she is actively involved in all teaching, research, and academic activities of the institution. She is also having pursued she is a certified TCC counselor, and she is excellent in CBCT reporting. With this small introduction, now I invite all our students to hear about xylography from Madam. Welcome, ma'am. Hello, Dr. Gigi.
Hi, sir.
Yes.
Good evening. Today's my topic is xylography. So at first, I thank ASMIC and Assisia College of Dental Science for giving me this opportunity to participate in this rapid review session. So I'll just brief what all things that will be asked about xylography. Ma'am has already discussed about salivary gland diseases. So xylography, this is a small topic. So usually xylography is asked as a 5-mark questions. So coming to the questions, in 2010 scheme, this xylography was asked as an essay question. That is, what is xylography? Mention the indication, contraindication, contrast agent used in xylography. Add a note on xylographic features of salivary gland in health and disease. Then again, it was asked as a 10-mark question. Describe the indication, contraindication of xylography. Describe in detail the contrast media and the stepwise procedure for submandibular gland xylography. 5 marks, it was asked as xylography itself. Then next, enumerate characteristic xylographic appearance and corresponding pathologies. That was also asked as a short essay. 3-mark questions. So next, how to write these questions. So first, we have to write the definition, indication, contraindication of xylography. Then contrast media used in xylography. So it's advantage and disadvantages, different types of contrast media. Then phases of xylography, xylographic techniques. There are 3 techniques. Then xylographic appearance. So different xylographic appearance that in normal parotid and normal submandibular gland. Then in disease conditions also. That's like Sjogren syndrome, xylodinitis, benign tumor, xylodochitis, xylolithiasis, and xylodinosis. If your time permits, you can write also this MR xylography and interventional xylography. So in some universities, I have seen questions like this. MCQ xylography is asked as MCQ questions. So for example, bone in hand appearance. Bone in hand appearance is seen in 4 options will be there. Benign salivary gland tumor, malignant, then xylodinitis, xylodochitis. So you can select the correct answer. Next, coming to the definition. According to Eric Weitz, the xylography, it is defined as a radiographic demonstration of the major salivary gland by introducing a radiopaque contrast medium into the ductal system. So, and according to Schaefer, this is a retrograde injection of radiopaque material into the duct system of a salivary gland, and the study of its distribution by radiograph. Both are same, that is xylography. It is the radiographic demonstration of salivary gland by contrast medium, and the ducts can be visible. Ductal system can be visible in the radiographic image. So indications of xylography include, we can evaluate the intrinsic and acquired abnormalities, then clear visualization of the branching ducts. Then if there is any ductal obstruction like xylolith tumor stricture, that is narrowing of the duct, these can be recognized by xylography. So indications include to determine the position of calculus, to assess the glandular destruction, and also to assess the function of salivary gland. Coming to contraindications, in certain cases, xylography is contraindicated. For example, if a person is allergic to iodine or contrast medium, we cannot do xylography. In case of acute infection of the gland, that is escape of the contrast medium to the acinar cells, that will lead to severe foreign body reaction. And also third one, xylography, contrast material used in xylography may interfere with the thyroid function test. So this xylography thyroid function test should be done prior to the xylography procedure. Fourth, that is calculus close to the ductal opening. While injecting the contrast medium, it may push the calculus back to the main duct, so where it may be inaccessible. So these cases, it is contraindicated. Contrast media should have a property similar to that of the saliva, and it should not have any toxicity, local or systemic toxicity. Then it should provide a satisfactory radio opacity while taking radiograph. Then it should also have low surface tension and low viscosity. So types of contrast media include ionic. There are two types, aqueous and oil-based. Aqueous solution include ionic and non-ionic. Ionic example, diatrizoate, and non-ionic iohexol. Oil-based solutions include iodized oil and water-insoluble organic iodine compounds. So advantages and disadvantages of this contrast media. So water soluble means that have a low viscosity, so it can be easily introduced. But and also it is easily and rapidly removed from the gland. And the disadvantage includes, since it is less radiopaque, since it is less viscous, it is less radiopaque and is reduced, and it have reduced contrast. Then it will be retained in the gland for a short time. Lipid soluble, the advantages include it is a dense radiopaque. It have a good contrast. Since it is highly viscous, it will be slowly removed from the gland. Disadvantages include long time retention in the gland due to the high viscosity. Then risk of foreign body reaction, does not flow easily into the gland due to its high viscosity. So these are the armamentarium for xylographic procedure. This include xylographic cannulas, set of lacrimal dilators, then contrast agent, syringe and gauze, then secretagogue, that is to stimulate the salivary flow, and high-powered magnifying glass. So these are the phases of xylography. There are three phases: preoperative phase, filling phase, and emptying phase. So in preoperative phase, scout or preoperative radiograph is taken before the introduction of the contrast medium. That is mainly to note the position or presence of any radiopaque calculus, then to assess the normal anatomic landmarks, and also to assess the exposure factors. Then filling phase. In filling phase, after the preoperative after taking the preoperative scout radiograph, the relevant duct opening is identified, then probed, dilated with lacrimal dilators, then cannulated. So after that, contrast medium is injected. So there are three main techniques available for introducing the contrast medium, that include simple injection, hydrostatic, continuous infusion, pressure monitored. So when this is complete, a filling phase radiograph is taken, usually at two different views at right angle to one another. So after this, this is the second radiograph, filling phase radiograph. And next, emptying phase. After this, cannula is removed, patient is allowed to rinse the mouth. Then again, our patient is asked to suck on a lemon wedge, that is to eliminate the contrast media. And after 1 and 5 minutes, the emptying phase radiograph is taken. usually oblique lateral. This is to assess the function of the salivary gland. So, in short, first we have to take a scout film or a baseline radiograph of the required salivary gland. Then ask the patient to suck on a lemon wedge to open the duct. Then identification and location of the duct orifice. Vicinity of the orifice is right. Then exploration of the duct orifice with a lacrimal probe. The probe should be slide easily back and forth and also to rotate freely without any dragging. Then after that, cannulation of the duct. Salivary cannula is held in place either by taping the tube onto the face or by having the patient bite on the tubing. Then introduction of the contrast agent and ask the patient to raise hand if he feel tightness or fullness of the gland. That is, we can inject about 2 ml of contrast medium to the parotid gland and about 1 ml of contrast medium to the submandibular gland. So again, after the radiograph, patient then sucks on a lemon wedge to evacuate the contrast medium. Again, third radiograph is taken, post-procedure radiograph, that is to check the secretion of the gland. So this is the procedure of xylography. Next advantage, high resolution of the ductal system, localized radiation dose, information about some specific disease stage like sialadenosis, sialadenitis, Sjogren syndrome, etc. Then disadvantages include it may be painful on injection, tissue necrosis may occur, single gland can be examined at a time. If allergic to iodine, this cannot be done, then difficult to interpret with precision. So coming to xylographic technique, there are 3 techniques. So using first is simple injection technique. This is done with a gentle hand pressure until the patient experience tightness or discomfort in the gland. So I have already told 2 ml can be injected to the parotid gland and 1 ml can be injected into the submandibular salivary gland. Hydrostatic means an aqueous contrast medium that is allowed to flow freely from a reservoir into the gland under the force of gravity until the patient experiences some discomfort. Third, continuous infusion pressure monitored. Here, constant pressure is flow is maintained and the duct pressure is monitored throughout the procedure. So the resulting radiograph is called xylogram. This is mainly to investigate submandibular and parotid gland. Sublingual gland is not done in this way due to difficulty in cannulation. So these are the xylographic images of normal parotid gland, that is tree in winter appearance. So here the branching duct structure tapers gradually towards the periphery of the gland. So next, this is normal submandibular salivary gland, bush in winter appearance. So this is Sjogren syndrome. Here there are, the appearance is called as snowstorm or punctate sylectasis, cherry blossom, and branchless fruit-laden tree. So these 3 appearances are same. This is mainly caused by weakening of the epithelium lining the intercalated duct. So that allows the escape of contrast medium out of the duct. So that will appear as dots or blobs like snowstorm or cherry blossom appearance. So this is sialadenitis. The appearance is like dots or blobs, also called as sylectasis. This is mainly caused by inflammation of the gland, producing dilation of the acini. So we have seen that the appearance, xylographic appearance of sialadenitis and Sjogren syndrome, they are 2 different conditions but are similar. Mainly, so first picture A, that is the normal intercalated duct and acinus. B, that is Sjogren syndrome condition. Here the epithelium lining the intercalated duct weakens, and that allows the escape of contrast medium out of the duct that produce dots or blobs. That is snowstorm appearance. So in third picture, that is sialadenitis, acini become dilated, that result in the collection of contrast medium, and that will give appearance of dots or blobs. So these two xylographic images are similar. This is case 3, benign tumor, and xylographic appearances, ball in hand appearance, ball in hand. This is xylodochitis. Xylodochitis means ductal xyladenitis or inflammation of the duct system of the salivary gland. So this the xylographic appearance is sausage link appearance. Next, xylolithiasis. So here xylographic images in uncalcified xylolith, it appears as a filling defect. In calcified xylolith, that appears as a bright radiopacity or dense radiopacity. So xylographic appearance of calculus include a filling defect or a ductal dilatation. So this is also a salivary calculus in the main duct. See here, this is the emptying film, a third film. So third film of the same gland. Here the contrast medium that is retained behind the filling defect. So that means there is a calculus. So emptying secretion is not fully excreted out of the gland. Next, sialadenosis. So here, this is the non-neoplastic. Sialadenosis means, ma'am already discussed, non-neoplastic, non-inflammatory enlargement of the salivary gland. Its appearance is leafless tree pattern. So this mainly due to hypertrophy of the acina cells that compresses the finer terminal duct that result in the leafless tree pattern that is seen in sialadenosis. So these are about the radiographic appearance of normal parotid and submandibular gland and also the disease state. So next, xylography may also be done using some advanced imaging techniques like CT, MRI xylography. So this is the MR xylography of the normal parotid gland A, and B, that is the MR xylography that's seen in Sjogren syndrome. So the main advantage is that here no contrast agent is required. Next, interventional xylography. So till this we have discussed about the investigation part of the xylography. Here this is the management part of the xylography. So this interventional xylography include balloon catheters and small Dormia basket under fluoroscopic guidance. So the balloon catheter that is inflated once it is positioned within the duct that produces the dilatation of the strictures or narrowing of the duct. Then Dormia basket that mainly used to retrieve the calculus, ductal salivary stones. So both these procedures are mainly used in the salivary gland obstruction, either by stricture or calculus. So without the need of any surgery. So this is silendoscopy that is use the this basket and loop method along with the silendoscope. So these are about the xylography indication, contraindication, then contrast agent, different types of contrast agent, indicate advantage and disadvantages of contrast media, then xylographic image of normal parotid, submandibular gland, and then some disease conditions like Sjogren's, sialadenitis, xylolithiasis, sialadenosis. Then next, advanced technique like MR xylography and interventional xylography. Thank you.
Any doubts for our students?
Dr. Gigi, could you please stop sharing your screen?
Yes, ma'am. Yes, ma'am.
I request Dr. Shabil to present the certificate of appreciation to Dr. Gigi. Thank you, Dr. Gigi. It was an excellent presentation, and you confined it for the importance of students in terms of writing examination questions. Thank you very much.
There is an important announcement. There will be no rapid review sessions tomorrow. So the next session will be on Monday. And the topics are radiation biology and dental considerations in systemic diseases. Thank you all. Good night.